This brief lecture is going to overview the diagnosis of opiate use disorder as well as discuss the multiple treatments available for this disease. When we take a look at the organizations who govern healthcare, we can see that a majority, if not all of them, support the use of medication-assisted treatment in opiate use disorder, including but not limited to the National Institute of Health, the American Society of Addiction Medicine, the Center for Disease Control, and the United States Food and Drug Administration. Not only do these organizations support the use of medication-assisted treatment, but we at Cooper Hospital and Cooper University Healthcare also support the use of MAT in patients with opiate use disorder. To make the diagnosis of opiate use disorder, it's important that we look at the DSM-5 criteria for substance use disorder. Most patients presenting to an inpatient hospitalization at our hospital meet the diagnosis of an opiate use disorder for at least a mild diagnosis or mild severity. If we go through this list of the 11 criteria, patients often meet tolerance and withdrawal if they're using intravenous heroin, and they've often had medical complications related to their opiate use disorder, and just having those 3 of the 11, they meet the diagnosis of a mild opiate use disorder and would qualify for treatment with medication-assisted treatment. Obviously, if they meet more of the criteria, the severity of their illness increases. So now that we've discussed that most of the patients who we see in the hospital can be accurately diagnosed with an opiate use disorder, does it even work to start medication-assisted treatment on them? And the answer is yes. We know that it improves patient survival. We know that it increases their retention in treatment for their substance use disorder. We know that patients who are on MAT have a decrease in the illicit opiate use and a decrease in other criminal activity who are on MAT. We know that it increases a patient's ability to gain and maintain a job, and we also know that it affects a person's risk of contracting HIV and hepatitis C, given the fact that the patients have a lower risk of relapse if they're using intravenous drugs. And then lastly, in the pregnant population, it's been shown that patients on MAT have improved birth outcomes compared to those who do not or who are not treated. When we're talking about relapse and addiction, we have to compare it to other chronic diseases, and we know that relapse is a part of all chronic disease. We know that we see patients with DKA for their type 1 diabetes in the hospital multiple times. We see patients with hypertensive urgency and emergency multiple times, and we see patients with exacerbations of their asthma or COPD for multiple times. And the rates of relapse for all of those conditions is actually higher than it is for drug addiction when a patient is started on treatment. So I think it's always important to understand that this is a chronic disease. Relapse is a part of that chronic disease, as it is for all chronic diseases, and the rates are not any higher when comparing to other illnesses. When we look specifically at opiates, and not just all substance use disorder, we know that opiates have a higher rate of relapse after acute detoxification. So up to 70% of patients who are acutely detoxified off of opiates and then not continued on medication-assisted treatment, their risk of relapse is extremely high. And a study done in 2010 demonstrated that patients who were using intravenous heroin actually had an even higher rate of relapse, up to 91%. And a majority of those who relapsed after that acute detox did so within the first week of discharge. This graph is just a graphical depiction of the rise of heroin use within the past 10 years or so. If we were to expand this out, the natural and semi-synthetic opiates is actually climbing up close to heroin, given the rise in use of fentanyl But as you can see, there was a dramatic increase in 2010 when the formulation of Oxycontin changed, and we can see this increase to use of heroin around that same time to where we are today. We know that medication-assisted treatment reduces relapse. So this graph is a representation of patients who are engaged in care, and then the relapse rate per 100 months in treatment. So as you can see, patients on buprenorphine, patients who are on methadone have much lower rates of relapse as opposed to patients who are on just behavioral treatment alone or non-opiate agonist therapy. So what are the options for patients who are presenting to the hospital for whatever acute illness they may have, but also suffer from opiate use disorders? The three that are approved by the Food and Drug Administration are methadone, buprenorphine, and naltrexone. The easiest way to kind of look at these three would be agonist therapy, either full or partial, or antagonist therapy with naltrexone. And we're going to go into each one of these separately. So if we take a look at the mechanism of action of each type of medication-assisted treatment and how it works on the mu-opiate receptor, we can see that things like methadone or full agonists will bind to the opiate receptor and create a full effect. The partial agonists, such as buprenorphine, bind to that same receptor, but they generate a partial effect or a limited effect. And then the antagonists only really perform a blocking effect, but not a negative activation of the receptor or negative effect. So that's something that some patients are sometimes worried about with antagonist therapy. So agonist therapy, these medications bind to the mu-opiate receptor and they activate them. Most patients will feel an effect of that opiate, and the magnitude of the effect differs with the drug and with the dose. So obviously a lower dose of methadone will produce much less of an effect than a higher dose until someone has built up the dependence for that substance. And we know that full agonist therapy does produce physical dependence, so that when patients are reduced or stopped on these medications, they will often experience, or they definitely will experience, withdrawal symptoms. The first full agonist therapy that was approved for the treatment of opiate use disorder is methadone. This is dosed at opiate treatment programs with daily observed therapy. There are two within the area, one in Pennsauken and one in Camden, that the majority of our patients are referred to. The initial doses must be observed. This can be done either in the hospital or at the treatment program, and as the patient progresses through the program, they are often progressed to the point where they get take-home doses of the medication, usually for a couple days a week or weekend in the beginning, and then as time goes on and they continue to progress up to weeks at a time. Candidates for methadone treatment are usually referred to in an appropriate clinic, either in the hospital or once after discharged if they follow up with us in addiction medicine. The second agonist therapy or partial agonist therapy that is available is buprenorphine. This is a partial agonist of the mu-opiate receptor. This image is a picture of the Suboxone film that we can prescribe our patients. That is a combination of buprenorphine and naloxone. So buprenorphine is available as a monoproduct, which is Subutex, pure buprenorphine alone, and then the combination product pictured to the right, Suboxone. The combination product carries less risk of misuse, since if injected, the naloxone is active, whereas if it's taken sublingually, it's not absorbed, and therefore the patient should not have any symptoms of withdrawal. This is generally a very well tolerated medication, and there's very few adverse reactions to this. And another good aspect of buprenorphine is that there are very few drug-drug interactions. Here we have just a graphical representation of receptor activation with dose of methadone. If we were to, this is a log of dose on the x-axis, but if we were to look at methadone, majority of opiate receptors where this curve starts leveling off is probably around 50 to 60 milligrams. For buprenorphine, that leveling off occurs probably around 12 to 16 milligrams. And then the doses above that tend to just kind of occupy very minimal more receptors due to the sigmoidal nature of the drug's binding. And then, as you can see, obviously antagonist therapy, regardless of the dose, is not going to cause any activation of the receptor. So like I mentioned before, with buprenorphine binding to the opiate receptor, you get maximal binding around 12 to 16 milligrams, and as you increase to 24 or 32 milligrams, there's very few receptors that are occupied by the increased dose. And if we take a look at the size of the film, a 8 milligram film of buprenorphine is a little bit bigger than the size of a dime, and we can have patients split this dose if they're titrating down or if they're tapering down to as little as an eighth of a strip. Just wanted to make a brief note about injectable buprenorphine. So approved almost 2 years ago now, or about a year and a half ago now, is the formulation of buprenorphine that is a depot. We've had 1 or 2 patients in our clinic get this medication. It's extremely expensive. It lasts for 30 days. Patients need to be stabilized on sublingual buprenorphine first. And the ability to have Medicaid pay for this has been a struggle due to its high cost, but obviously much lower potential for abuse or diversion as it's a monthly depot injection. Hopefully we can start transitioning a lot of patients to this in the near future to kind of lessen the risk of some of those negative aspects of treatment. So when we look at antagonist therapy, antagonists bind to the mu-opioid receptor and do not activate them. They act as a pure blockade. The 2 antagonists that are available for the opioid receptor are naloxone and naltrexone. Naloxone is known as Narcan. It's the antidote for opiate overdose. It wakes people up pretty instantaneously, but needs to be usually given in multiple doses depending on what and how much a patient has ingested or injected. And then naltrexone is a longer acting antagonist that is used for the prevention of relapse to opiates. It's offered in a oral form and a long-acting IM injection as well. In 2010, the FDA approved Vivitrol for the prevention of relapse to opiate dependence following detoxification. So patients who are detoxed from opiates, including partial agonists such as buprenorphine, can then be transitioned to Vivitrol. A lot of times this will not happen in the acute hospital setting due to the fact that the first dose can be given no less than 8 days after a dose of agonist therapy, including partial agonists such as buprenorphine. So a patient would need to be fully detoxed from full agonist therapy with or without the use of buprenorphine, and then transitioned to Vivitrol after that. And basically, because of that, there's a need for managed opiate withdrawal prior to starting this medication. The risk of precipitated withdrawal when going from agonist therapy to antagonist therapy is very high. And that's why we cannot give this medication no earlier than 7 to 10 days after either partial agonist or full agonist therapy. Some of the side effects of extended release naltrexone or oral naltrexone: liver toxicity. So patients who have cirrhosis or end-stage liver disease some medication needs to be avoided. Injection site reaction, obviously monitoring the site following this injection, and depression and precipitated withdrawal would be the last two. So depression is something that needs to be screened for prior to starting this medication, most notably the presence of previous suicide attempts. But a history of depression in itself is not a contraindication to starting this medication. And then precipitated withdrawal, like we discussed before, can be a serious reaction if given too soon. A recent study done in about a year and a half ago looked at buprenorphine and naloxone or Suboxone sublabel tabs versus extended release naltrexone, and looked at retention and treatment. And it looked at things like cravings, and it looked at relapse, and what it showed was that patients had very similar cravings when they were started on medication-assisted treatment, and their cravings were less than those who were not started on medication-assisted treatment, leading to less relapse in those patients on medications and a higher retention in treatment. What are some considerations that need to be made when we're choosing what medication-assisted treatment is right for our patients? First, we need to discuss the patient's want or desire not to have any physical dependence to a substance or medication. So full agonist therapy and partial agonist therapy will cause physiologic dependence, and patient will have withdrawal symptoms when medication is discontinued or tapered. Physiological dependence is often mistaken as being addicted to the drug, and it's a conversation that we often have with patients who say, I don't want to be addicted to another substance. I'm trying to stop using heroin and I don't want to just switch it out for another drug. But having that discussion with them that physiologic dependence can happen to all sorts of different drug classes, and it's not specific to opiates. It does not mean that they are addicted to their therapy. It just means that it needs to be tapered off slowly when the time is appropriate. Methadone produces a high physiologic dependence. Buprenorphine would be a low to moderate physiologic dependence due to its partial agonist therapy or properties, and Vivitrol has no physiologic dependence related to it because it does not activate the receptor. So after kind of reviewing those options with them, one of the important things to do is talk to the patients about what they have tried in the past. So even if they have not been prescribed either buprenorphine or methadone in the past, they've probably taken those medications illicitly to avoid withdrawal symptoms in the street. So talking to them about what has worked for them in the past, either for withdrawal or for treatment, is important, and what they may or may not prefer. So discussing what treatments they've been successful on versus what treatments they have not been successful on, and why they would want to continue one or start one at this time. And then we have to look at the treatment environment. Where are they going after discharge? So are they being discharged to a skilled nursing facility where they're going to be able to get their medication? Where are they going home to a situation where other people are using in the house, or they have good sober support and they don't need to be monitored on a daily basis? Or are they going in for substance use disorder treatment at an inpatient setting? And what's going to be available at all these settings? So a lot of this plays into the decision at the time of discharge or at the time of initiation of treatment. Do the patients need to be referred to outpatient providers such as us in the addiction medicine clinic, or an opiate treatment program for methadone, or us for naltrexone injection a couple of days down after discharge when they're safe to start that medication? This is the last slide, and I just have this in here because I just wanted to point out that while we know that relapse is a part of the disease, we know that medication-assisted treatment can be helpful in preventing relapse and reducing cravings. So it's important to start patients on these medications early and continue them on their medication until they've developed a long course of sobriety and develop recovery from their illness so that they can maintain that sustained recovery. Because we know that with time, the chances of relapse tend to or will decrease. And so engagement in treatment is important, especially early on. When we can engage patients who are acutely hospitalized and start them in treatment, it's important to set their follow-up so that they can continue that treatment for a long time. Thank you for taking the time to review the diagnosis and treatment of opiate use disorders, including the 3 types of medication-assisted treatment. If you have any questions, you can always email me or any of the other faculty in the addiction medicine department, or always find us on call as well. Thank you so much.